My name is Egbert Zonder. I'm the second on the row. This presentation is done on behalf of the Rebuild Consortium in the UK. And unfortunately, our first author, Natasha Palmer, could not be here. And also some complexities why the study is a bit less advanced than we had hoped for. But we hope for your input so you can be part of this research. So it's taking a longer view. I think the presentation we've just heard, they have circled around a certain event in this particular COVID, covering a couple of years. We are covering 20 up to 40 years. So it's quite daunting. So we also like to hear what you think about that kind of efforts. So we want to take the longer view on resilience in Afghanistan. But there is a common view which has emerged in particular over the last few years regarding the resilience of the system in Afghanistan as it existed. So there is quite some literature, relatively a lot of literature on the health system in Afghanistan over the past 20 years in particular. And all those articles, as well as all the presentations which have ever been given by anyone, and including all the webinars which have been given, history starts in 2001. That's quite striking. And then the story unfolds. So that story is based on a novel approach to rebuild the health system following that time that the Taliban was removed, following 9/11. You probably know the story. And that proved quite successful in terms of health outcomes. Health outcomes were obviously very poor in Afghanistan, in particular at that stage and still. But that novel approach did help improve health outcomes. So it was implemented throughout the country and including the insurgent areas. Because as you may know, ever since the insurgent areas, the Taliban gradually came back over a period of 20 years. But that included, their areas were included in this new approach. And everyone thought, no, this is going to collapse when the Taliban returned in August 21. But against all odds, it re-emerged. As people say, hey, it is resilience after all. So I'll get back to that. So what, in fact, was that novel approach? In 2002, so after the Taliban first time was removed, and the international community came in and wanted to make a big success of Afghanistan, the international community, with the Ministry of Public Health, started defining a new health policy. There were some major donors who set their force and monies behind that. It's in particular World Bank, USAID, EU. And that health policy was a health policy and with immediately an implementation model, which is quite unique. So the health policy was, so what we are going to deliver a basic package of health services, really very basic, primarily focused on maternal and child health to all Afghans. Underline all because you want to include the whole population now. And the implementation was that we split the government function into, because the government was used to run the whole health services, but they're going to be limited to setting the policy, to regulate, to procure, and to monitor. And then you need partners who can implement the health services, and that was done at the time. It seems to me most logical to ask the NGOs who had been there for quite a while and knew how to run health services in the periphery to contract them. And so they were contracted through competitive bidding, and that was a model which had just been tested out a couple of years before that in Cambodia, but now it was going to be implemented at full scale in the full country. This was the basic package. 1 or 2 years later, an additional package was formulated. It was the EPHS, which is the kind of essential hospital package. So as soon as this became implemented, results start showing, in particular in those fields like mother and child health, was it intended to be, as these graphs quite clearly show. You always wonder attribution, but I think there are some good arguments for attribution of this whole program. You see both indicators gradually going down. So this was the thing which was ongoing, so this whole delivery of the BPHS and the EPHS was ongoing ever since 2003, 2004, up to 21, and even up to today, as I will reveal later. So quite a similar approach. There was this ongoing contracting with the NGOs through competitive selection based on quality and cost. The Ministry of Public Health, they are in charge of contracting the NGOs. Of course, donors were behind it, they were providing the money, but the Ministry of Health took, after a while, fully charge of those contracts, asked them to go to a defined geography, usually a province, so quite relatively tiny NGOs running whole provinces of 1 million or more people, quite amazing, in fact. The contracts were managed by the Ministry of Health. There were clear objectives, and the payments were increasingly linked to third-party assessment of the results. So there was a lump sum agreement, contracts, so to maximize flexibility. That was some of the thinking behind it, to encourage innovation. So the initial contracts were largely won by the NGOs, 3/4 it said, but it means that 1/4 was already from the start run by local NGOs. It's a quite unique feature that if you emerge from more acute conflict, that you have so many NGOs who can do that. Gradually, the NGOs were replaced by local NGOs. A feature of this whole system, which has been running then for 20 years, it was fully dependent on donor monies. Of course, every year someone raises hand, should we not make this more sustainable, having some more domestic fundraising? Yes, we should. And then it went on, and still the money did come from abroad, almost really, literally, fully. So this was a situation up to 2021. This is kind of a simplified version of the system, but you have the 3 donors through a pooled fund. They insert kind of 150 million annually for 35 million Afghans, so do make your calculations. So everything is administered by the World Bank, and then it goes to the Ministry of Health, who administers that money, who administers the contracts, and asks the NGOs to provide the services. So this was running, and it was ongoing, and there was not much innovation anymore because of the increasing insecurity, I think. So then this happened. I think you probably will remember in August 21, the Taliban, a bit faster than everyone had thought, appeared on the stage again in Kabul. A lot of people left, including many health workers. And the Taliban took over the government again. They became the de facto authorities, that's the normal term to address them, because they are internationally not recognized. All the national assets which they still had at banks in the US and other places were frozen, and there was an immediate end to any development money. So everyone said, this health system is on the brink of collapse because it's so fully dependent on that money. And the articles were then in newspapers, in medical journals, this is going the wrong way. But then so this was still the situation at the end of 2021. And this was then what was happening. Those funds were frozen, so no more money to the ministry, no more money to the NGOs. And NGOs typically do not have any spare cash in their pockets. So that was the threatening collapse. Through a few hopes, but again simplified, after 6 months, 7 months, this happened. Somehow the money was unfrozen, again, at least the money which the World Bank still had, and it was channeled through UNICEF. And UNICEF took over then that role of the Ministry of Health and started to make new contracts with CNs to provide the same services. And that worked quite well. And amazingly, people managed to get that all done. So that's, of course, bypassing the Ministry of Public Health, which are not really an acceptable partner to talk to. But on the other hand, you don't want to leave Afghans behind. So there was all this dilemma, soul-searching, what to do. Of course, the whole role of women, and that was not nice anyway, but still you want to do something for the people in Afghanistan. That was very much also the thriving force behind people who are working in that area. So there has to be some negotiations with the MOPH. You cannot work in a country without talking to them at all, but really at practical levels. So there was another element, national hospitals, huge hospitals, in particular in Kabul. They were typically financed by the MOPH, also traditionally, but MOPH, no cash at all. So in particular ICRC stepped in for a while, but also because of all the crises in the world, they started to get cash-strapped and they had to stop it. So then the Ministry of Health had to take over, and that's what they do now. And of course, with much less money than in the past. So this is the situation, that common view. Said, okay, well, after all, it was not so bad. The system was resilient. As long as you manage to channel that money, you can continue the system. It's wrong that it's so dependent on external forces, but yeah, what else to do? You can do it. So we were looking more recently at that aspect. They said, well, there's still something not fully right. And we looked at the literature again, and we thought, well, we want to take a longer and in particular also wider view, because I think certain elements are overlooked in this whole story. And I think there was a bit of a risk of a foreign gaze, and that comes also from all the publications which you can see in the BMJ, Global, Zoo, but so many other articles have been written, starting that story with in 2001, neglecting that there has been things going on. The conflict is much older. It's like 40 years. And it had so many phases, and things happened during those times. And in particular, NGOs were groomed, and they were supported to work there. And that element was forgotten. So they were there to do this, to be subcontracted. And there has been substantial inputs by other stakeholders. In particular, other NGOs have done things. The other UN has done things, family health houses by the UNFPA, and the role of community health workers is not so clear in this whole story. And there proved to be many, many mobile health and nutrition clinics, also interesting political economy aspects to that. It's a thing the Taliban did not like anymore, but it was a substantial contribution. So we also saw there were missed opportunities. Sticking to the same package for all those years, is that right? Neglecting...
Sorry, but if you can wrap up.
Yes, I wrap up. Nancy, is that the package was too low. It's only $5 per person. For all those 20 years, other packages have a more other approach, and there is continued concern that has been there for years and years of extremely high out-of-pocket payments, which the population of the Afghans still face. So this was our perspective, wanting to do the study. So this is what we do. We will do a lot of interviews and the typical things which you do in this kind of really case study. And we want to ask you, do you see any scope in doing such a case study which goes much longer back into history, and does it have any wider resonance, this whole story?
Thanks very much, Jacob. Sorry to